Okay, we are recording. Today is week 10. We are going to do a review today. It's a strictly review. Then next Tuesday, you have your HESI during your lecture time. Okay, sign up for your HESI. Okay, make sure you do that compatibility check. Take all the stress out of everything by being prepared. All right. Okay. All right. And then that's next week. And your attendance I will get from your HESI exam. All right. Now, the following week is week 12 and attendance must be taken. So I will be setting up a time. Now, for those in my class, I will be setting up a time that you'll meet with me and be on time. It'll be during our lecture time. And so that we can do an end of module assessment and then your grade. All right. And be sure, guys, HESI, you need to remediate. No, nothing. You can't say, oh, I did really good. Good. You still have time. You still have to remediate. All right. If you don't remediate, you will get a 0. And that breaks my heart. Okay. Because that HESI is worth 20% of your grade. So you do not want to get a 0. So you must remediate. And you do that after your HESI exam. All right. So now that we got that out of the way, I just want to welcome Professor Dottie's class. Hi, Jacob. And there's Mr. Patrick. There's Erin. Hi, Erin. I see your eyebrows. Oh, there she is. She's okay. There she is. All right. Dubaka. Okay. Hello. Let's see. So everybody in my class, say hello to Professor Dottie's class.
Hi, Dottie.
Hello.
Hello.
Yeah.
Hey, Nicole.
Here we go. Are you ready? Thinking caps on. Okay. So I'm going to share my screen. And remember, what you put into this is what you get out of it. There's no magic. There's just no magic. Okay. So let me see which one I have here for you. Okay. So what I did was I took the exam and I put it into 4 areas on the HESI exam. Go ahead and mute yourselves right now. So these are the 4 areas that you will be tested on. So safe and effective care, health promotion and maintenance prevention, psychosocial integrity, and physiological integrity. Okay. Please mute yourselves. Everybody? Okay. So under safe and effective care, these questions are going to be about patient safety. So if you've done enough questions, say in Saunders, and you can notice that they come for what? Patient safety. So you want to, the nurse must prioritize the delivery of patient care. Now, this is an important question, and you'll see there's a lot of reviews. Ask yourself, if I can only choose to do one thing, okay? If I can only choose one thing, what would it be? Okay. I'm hearing some background noise. Could you please mute yourself? Then implement.
Jesus, my God.
Okay, I'm going to stop sharing. Okay. And I'm going to see who is not muted. Mute. Okay, mute. I think I got it. Okay. You need to be on camera. The same rules go for any other week. If I don't see you, I will mark you absent, or I could remove you from this Zoom. So you choose. Okay, I'm gonna go back. Oops, that was my other PowerPoint. Sorry about that. All right, now let me see, where's my, I have so many reviews. Oh, sorry about that. Oh, I just had it. Where is it? There. Let me see. Oh, sorry. Usually doesn't happen to me, but I have so many reviews here now that let me find my review. Okay. All right. So what you want to do under this area of safe and effective care is, again, they have so many questions on the nurse prioritizing. That's why I'm going over it, because it's notorious. So you want to be able to say to yourself, if I can only do one thing before I left this room, what's that thing going to be doing? So like a lot of people put down, well, call a physician, call the healthcare provider. But are you going to just do that? Or are you going to turn your patient to the left side if she's having maybe late decelerations? What happens if she's bleeding and she's she'd be hemorrhaging? Okay, what are you going to do? So this is just a way to help you decipher out your prioritizing. And it's true in real life too. If you come across a patient in a room and she's hemorrhaging, she's bleeding, you're going to do something before you leave that room. Are you not? Yes. Okay. So the next one is an area that you want to implement maybe seizure precautions. Say, I'm thinking of what? Safety. Okay. So you think about the complications that could cause a seizure. What complication in maternity causes a seizure? Well, preeclampsia.
Preeclampsia.
Yes, exactly. So you want to keep that patient safe, do you not? So you have her and you make sure that what? She's free from harm. So like padding the bedside rails, you're keeping the patient safe. And then the last one area that falls under the safe and effective care could be follow security plans. Big time in maternity, guys, big time. And they usually, I can guarantee it, there'll be a question on the ID bands. Okay, it was on last HESI, it'll be on this HESI. It's so important for the nurse to check the bands. So after baby's born, baby gets 2 ID bands, mommy gets 1, and whoever she deciphers, her husband or her partner, whoever is in that room that she deciphers that she wants to have a band on, they have a band. It all matches. All matches. And we take it very seriously. And so if a band falls off, what do we do? Well, we just don't put it back on, because we have to then start all over again, and all 4 bands are done. And you do it with another nurse. We do it so we have a witness. Really, really important. And this I can guarantee will be on HESI. Okay. All right, the next area, let's see here, I go into is health promotion and maintenance prevention. Remember I said at the very beginning, nurses, we promote health and we want to prevent things from happening. Okay, so under this topic, you'll find several topics: postpartum complications, maybe like postpartum hemorrhage, hypovolemic shock, uterine atony. So what would the nurse assess on these type of patients? So I will be going over, after I get done with this portion, I will be going over postpartum complications. On the last HESI, there was 5 questions on postpartum hemorrhage. So I am making it a point to go over postpartum complications. Now, you all know what uterine atony is, correct?
Yes.
What is that, Patrick?
Soft and boggy.
Yeah, it's boggy and it's soft. So what atony means, A-T-O-N-Y, is a uterus without tone. That's what that word is, without tone. So I have a soft, boggy uterus. What's my patient going to be doing?
Bleeding.
Bleeding. Yes, bleeding. So what are you going to do?
Massage it.
Massage the
Massage
fundus.
the fundus.
Right. Okay, good. Now, hypovolemic shock. She's got a pulse of 120 after delivery. What's happening?
She's hemorrhaging?
Yeah, because that's tachycardia, is it not?
Yeah.
Mhm.
Yeah. So we got tachycardia going on. Shouldn't a woman's pulse after delivery be lower? Yes.
Yes.
It's supposed to be lower after delivery.
Right.
Hypotension.
They always like to put on there. So what are you going to do? Massage the fundus, right? Make sure that you don't have uterine atony, or what's another cause for a hemorrhage that I don't have on here?
Pieces of the placenta
The
being
placenta.
left
A retained placenta.
Yes,
placenta
great.
In placenta.
Placental fragment.
Right, retain placenta fragments. Absolutely. Okay. All right,
Laceration
good.
during birth isn't on there either.
Which one?
They can sustain lacerations in the vaginal
Yes,
canal
yeah.
during birth.
Right. So I just gave you an example of some, but that's why I'm asking what other? There's a whole bunch of them, are they not? Yeah. So you have lacerations, you have postpartum hemorrhage, you have what else? I'm thinking uterine atony, hypovolemic shock. Okay. So that's what you want to make sure that you go when you're studying this. You want to say, what will the nurse do in with this type of patient? Okay. Then the next area that's always on HESI, always, is Nagel's rule. They always want you to calculate the patient's estimated date of birth, right? Or EDC, EDB. So what's Nagel's rule?
the estimated due date. You count back 3 months and add 7 days.
That's
and then
right.
you're going to add that extra year if you say May, it goes back to February, you got to put the following year.
Yeah, it's all according to right. It's what's appropriate. So they always will ask you. So say in this case, if the first day, now it's the first day of a woman's last menstrual period was August the 12th. So what is her EDB? So count back 3 months, which is what?
3 months back.
July, June, and May.
May.
Right?
May.
Right. Then add 7 days to what? August the 12th, because that was her first day of her last menstrual period. And when did we do?
May 19th.
Add.
Right. Okay. All right. So if you're not good with that, then you need to practice. Okay. So the next thing they always have, and they had on last quarter, HESI, was gravida and para. And they did have one question on GTPAL. So what gravida and para, what gravida means what?
How many times you've been pregnant?
Any pregnancy.
Right. Okay. And para?
20
It's
weeks.
the number of pregnancy that average 20 weeks or greater.
Exactly. Okay, good. And I put even the HESI book as a reference there for you. So if you want to go and you can look that up also. Okay, so let's practice GTPAL because it was on HESI last semester. All right, so that means what? Gravida, term, preterm, abortion, and living, right? Or miscarriage. Okay. So you have a patient that comes in and she's pregnant. So she's coming in her first visit. You're going to do an obstetrical workup on her. Are you not? Yeah. Okay. So she's 6 weeks pregnant. She had healthy two. She had a 2-year-old. She had two 2-year-olds, twins at 40 weeks. All right. Okay. So there's my one. That's my term, right? Okay. She had a miscarriage at 22 weeks. Where's that fall under?
The P.
Under the P, right? Because it's more than 20 weeks. Okay. She had an elective abortion at 6 weeks, 5 years ago.
The abortion.
Okay. So what's my GTPAL? This is my 4th pregnancy, right?
4.
Right. Rabbit of 4. Term,
Is 1.
1.
1. Okay. Preterm,
Is 1 as well.
1.
right. AB,
1.
1. And how many living children do I have?
2.
Right, because I did have a set of twins, right? Right, this little set of twins here. This is where here, so we have 2 little boys right now when she came in. Okay, does everybody see that?
Yes.
All right, so you could be pregnant with, oh my God, say quads. Could be quads. Could be 4 babies in there, and then this pregnancy, but it's only 1 pregnancy. Okay, good. Okay, where we get the credit for is how many are living, right? All right, so everybody's good on that, right? Okay, I move right along. All right, so now we're again still in health promotion and maintenance. You provide care and education to an antepartum clinic, client or patient, or a client who's in labor. So if you're not good with antepartum, then go back in your book and look under antepartum. All right. When you're studying antepartum, you want to look at the different trimesters. So remember the first trimester, right? What's the biggest thing about the first trimester? Ambivalence. Yeah.
Like crap.
Yeah. That's a good one. I love it. Yeah. I've heard all kinds of different things when I came back and I said, well, it's just the rabbit died. And they went, oh no. Okay. And they have to get used to it. Okay. Well, sometimes it throws some big people off. I mean, they can have financial concerns. Think of our special groups. I'm thinking like the single mother. Doesn't she have concerns? I mean, she's got to work. She's finding herself throwing up. She doesn't want to call in sick. So she's got a lot of working things that she has to. She probably didn't expect this. So she got quite a bit of ambivalence about the pregnancy. And how about people concerns about their careers? Not so much today world that because they can't fire you if you're pregnant. Excuse me, but they have career concerns. Some people don't get they don't get promoted because of pregnancy. It just depends. Now we're going to go in the second trimester. So the second trimester, you have what? Quickening. What's quickening?
But that's the
Fetal movement.
yeah. There you go.
Yeah. That's when actually a woman, when she feels that baby move, think, wow, this pregnancy is really there. I really am pregnant. I really do have somebody growing inside of me. It becomes what we say becomes real. Okay. And then the pregnant woman accepts the pregnancy. The second trimester is also nicknamed the honeymoon trimester because now she feels better. In the first trimester, how is she feeling? What's going on in the first trimester that maybe is not so good either? What do you think?
Morning sickness.
Nausea and vomiting.
Yeah, nausea, vomiting. So no, what you're not, what would you give her to help her with her nausea, vomiting? That's not a medication. That you would give what? Ginger. We talked about ginger ale. How about the crackers? I think some crackers. Yeah, some crackers. So know that. So when you're studying these areas, write down, and write down what the nurse would do. Getting back to the second trimester, you have quickening and pregnancy becomes real. She accepts the pregnancy. She's going in for tests. If she's an RH negative mom, what does she need to make sure she gets?
Rogam.
Rogam.
Right, Rogam. Good. Okay. What tests do we do to find out if she's having any problems with diabetes?
The glucose
The
test.
Glucose
glucose?
intolerance test.
Yeah. Okay, so we first do the screening tests. And then if that comes out abnormal, then we're going to go on to do the 3-hour glucose test. Okay, that's what diagnosis gives her the diagnosis of gestational diabetes, is the 3-hour glucose tolerance test. Okay.
Professor?
Yeah.
So I'm very sorry to interrupt. My daughter just passed out downstairs. I have to leave the camera. I will be right back.
Okay. All right. Hope she's okay. Okay. Whew. Okay. Let's go on to the third trimester. Pregnant woman becomes what? Maybe introverted, and she's what? Concerned about herself, right? Okay, when is this baby coming out? I'm really tired of pregnancy. These are kind of psychological things that happen during the third trimester. Maybe she's having, what are those contractions called that are irregular contractions?
Braxton Hicks.
Yeah, Braxton Hicks. She could be having Braxton Hicks contractions and just really uncomfortable. What causes her to have like a waddling gait? People walking around like little ducks, huh?
Lightning.
Okay. What happens is the pelvis, right?
Yes, pressure on the pelvic. Pressure.
Yeah, it kind of opens up itself and relaxes, and so they got a little waddling gait. Okay, so let's move on to for a woman. Maybe I know they're going to have questions about women in labor. So when you have somebody in labor, we're thinking about contraction pattern. How often? What's the best contraction pattern? Every 2 to 3 minutes, lasting 60 to 90 seconds in duration. How do I know if a person is in true labor?
Because when they're walking, it makes the contractions more. You make them ambulate.
Yeah. If you send them out walking and then they come back and the contraction pattern has increased, and she's doing good. And what else tells me she's in true labor?
Water.
Opening of the cervix.
Yes. Opening of the cervix, dilation and effacement of the cervix. That's the biggest thing. Okay, Jessica, is your daughter okay?
Yeah, my daughter, she's got a blood disorder, and sometimes it affects her. And so we heard a loud thud, and my sister ran downstairs, and she had fallen. So, but she's okay.
Okay, all right.
Thank you. Sorry about that. Sorry, everybody.
Oh, no, that's okay. Well, now I can kind of go on. I was worried. Okay, so so for questions, could be about contraction pattern. What is tachycystole?
It's where you have more than 10
I think you know it. It's contractions that are every what? Minute and a half, right? Up and down, up and down, up and down. Is that good for the fetus?
No.
What can happen to the baby?
The heart rate.
What is that with their heart rate? Their heart
Their heart rate will go down.
Yeah, their heart rate goes down. They go, hey, every time you have a contraction, I got to hold my breath in here, lady. So if you're having contractions one after the other, that little thing has hardly any time to what? Recover, okay? So his residual oxygenation is going to be diminished.
What was that word one more time? Tachy what?
Tachycystole.
Good.
Okay. Or what's another term for that? Hyperstimulation of the uterus. Okay. All right. Go. You may see either one. I want you to be able to recognize it. Just like I want you to be recognize RHD, immune globulin, for ROGAM. Okay. All righty. We're moving right on. What's the, when you have somebody in labor, some questions about women in labor, sometimes they can throw in those questions about the station of the head. Okay, so what is station?
Below the
Okay, so it's the level where the baby's head is, right? So at the ischial spine, what station is that?
0.
Yeah.
Okay, above it is what?
Negative.
Negative.
Right, make -1, -2, -3, -4. What's below it?
Positive.
Positive.
It is.
Good. So that's how we can descend. So a lot of times in a question, like on these kind of tests, they'll give you the scenario. And so that's why you have to know about contraction patterns, dilation and effacement of the cervix, and station of the head. Okay, and how it descends into pelvis. Oh my goodness, if you had a macrosomic baby, what do you think are the complications related to a macrosomic baby?
Low glucose in baby.
Yeah, tearing.
Yeah, well, macrosomic. Okay, so let's start somewhere. Okay, let's start somewhere. Macrosomic is what?
A large
A
baby.
large baby.
Large baby. Those are big babies, big heads, right? Big shoulders, right? Okay.
Dystocia.
Shoulder
Yes.
dystocia.
Thank you. Yes, dystocia. So we don't want those women that have these huge babies, okay, to be in labor, correct? No, we probably would want to C-section them because they could get dystocia. They could be in labor and then get stuck, you know. They could actually make the way the head comes down, but then you deliver the head, and then what happens?
Then
The
you
head
got
gets
the
shoulder.
shoulder.
Then you have shoulder dystocia. What's a complication that's related to shoulder dystocia?
Babies can break their little
Tear.
lungs.
Well,
Episiotomy.
Prolapse.
well, yeah, you have episiotomy. What kind of degree would you probably have with that kind of a big baby?
Fourth, probably a fourth.
Fall.
Yeah,
Into a
yeah,
3 or
4. Okay. She could have internal lacerations too, could she not?
Yeah.
Okay. Then you have this big baby, and I guess his head is there. So how are we going to deliver that baby now?
Section.
Well, we can't section. His head is sticking out.
It's gonna have to be
Oh, you have to
push.
Well, we're pushing, but it's not coming anymore. What do we have to do?
No, I mean you got to get up
An
on your
emergency
head and push
C-section?
down.
the vacuum. No.
Well, a vacuum at that time is that
Or
the
faucet.
head is actually out now.
I think you okay there.
So I think I heard somebody say you're gonna have to break something. You're gonna have to break the clavicle. Yeah, exactly.
Oh my God.
Yes,
Really?
that's true. That's true.
Yeah. I've been on those. That was a sickening feeling to have this head stick is coming out, and the doctor looks up at me and goes, Irene, I need your help. And I go, sure. What you need? And he goes, this baby is stuck. And so I'm going to go ahead and break the clavicle. So he cuts the 4th degree, breaks the clavicle, and that releases the anterior shoulder, and little guy came out. Well, big guy came out. Oh my goodness. But he did very well. The children's bones do heal very nicely and quickly. Okay. If I have such a difficult delivery, what complication am I thinking about? That I have to be what? Thinking about?
For the mom or the baby?
The mommy.
Can you say that condition again?
Yeah, you have this difficult delivery. He had to maybe use a lot of pressure. Babies got stuck. Maybe had some lacerations in there. What complication am I worried about?
Hemorrhaging.
Yeah.
Hemorrhaging, absolutely. That's a difficult delivery. Be on the lookout for hemorrhaging. Okay. All right, getting back to baby. What's a normal fetal heart rate?
110 to 160.
Yep, 110 to 160. What is it called when my heart rate is below 110?
Bradycardia.
Okay. On the other hand, if my fetal heart rate is 180.
Tachycardia.
Okay. All right. What could cause my fetal heart rate to be 180?
Respiratory distress.
What complication of mom?
Hypertension.
Hypertension. What am I thinking of? How about infection? Mom has a temperature.
Endometritis.
Yeah, endometritis. Mom has maybe chorioamnionitis. She has a temperature. So baby can get tacky. That's what I wanted to present to you. Okay, what's field chop?
The different heart
variations, accelerations.
Good. So what's the V stand for?
variable.
And variables related to what?
Core
Compression.
Good. E?
Early.
And that's related to?
Yeah.
Head compression.
Compression.
Good, head compression. A is for?
Acceleration.
Acceleration. Good. And is A cells, are they okay?
Yes.
Yeah. Okay. And then I've got what? I got L.
Late deceleration.
Late deceleration. What is late?
What placental insufficiency?
Placenta.
Okay. Is late good?
No.
Okay, good. And situations where you have to make some decisions, you want to remember lying.
I love Richard and all, and I love Julian.
What is that?
I need y'all to really look
Yes,
at
I
me
know.
and think, am I
I'm mute.
you could ever pull?
All right, guys. I love you all, but
What?
let's go mute. Okay. All right. So lion. So lion stands for L for left lateral or lateral. Left side is preferable. Let me just tell you that. But lateral position. Get her. Don't ever let a woman lie on her, a pregnant woman lie on her back.
Yes, for this.
Because what can happen?
The vena cava.
That can
pressure.
You won't be able to get enough oxygen.
Yeah, right. Yeah. You get what? Compression, right? Okay. Supine. What's that called?
Supine. Supine position.
Hypotension syndrome.
Hypertension. Yeah.
You got it. I'm pulling it out of you. All right. So remember line L. I is for IV. Okay. O is
oxygen.
For good. N is for
notify the provider.
Yeah, I need help in here. I usually what I do when I have such an emergency, I turn my patient over to the left side. I got our IV fluids going. I got oxygen at 8 to 10 liters via face mask. And I'm saying, hey, guys, I need help in here. Okay. All right. And you might have it on the test that says notify physician. All right. If you're thinking about taking care of a woman in labor, you always have to think about what? The discomfort that's associated with labor. All right. So what are some non-pharmacological methods?
A finger one on the belly.
Ambulation, massage, fluoride.
Music.
Yeah, okay. Hydrotherapy. Did I hear hydrotherapy?
Hydrotherapy.
Yeah, good. Diversion.
Yeah, okay. You could dim the lights, make the area real less noisy and comfortable.
Yeah, those are some nice non-pharmacological methods. Fluoride, yeah, touch. If she doesn't have a support person with her, who can she hire?
Doula.
Doula.
A doula.
Doula.
Okay, good. Okay, they last HESI they threw that in there too, so that's what I'm asking. Doula. Okay, now doula is not a professional who has, I say professional who has a license. They're certified. They work along with the patient. They're there for the patient. They're there for support for the patient. And so it's a nice little team though, and especially works good if you got a husband in the room that, oh, he just can't stand blood or anything, and he doesn't want to be in the room that much, and can't support his wife as he should, then they'll get a doula.
You better grow up.
Right.
I love it. Yeah, some of them grow up right there in the labor room. Okay.
Oh, mine did real quick. He didn't want to grab a leg. I yelled at him. I said, you grab this. I said a few choice words. You ain't got no choice. You put this in me. Now you're going to stand there and watch.
Right.
He did.
I love it. You'll make a good nurse. Okay.
Quick question though about the pudendal block.
Okay. I was going to get there. Okay, go ahead.
Sorry.
Okay. All right.
Well, no, with the pudendal block, because you have a spinal and the pudendal with the block, would you use that on somebody who doesn't want like any type of numbing, but just for the very last minute, they can go in and just give that shot real quick so it doesn't hurt as bad?
Yeah, pudendal is, she's been doing really good the whole labor with the non-pharmacological methods.
Right.
But then we get to the point that we've been pushing, and even with the perineal massage, it just can't, the head is bigger than, they have figured. So they have to do an episiotomy.
Mm-hmm.
So you don't really want to cut an episiotomy if she doesn't have any kind of anesthetizing. So pudendal is where they go in with that big spinal needle, it's a long thin needle. And they go in and they anesthetize the pudendal nerves. And it works really great, like a charm, when it has to deaden the perineum right there. So it's kind of nice to get that. She's not getting an epidural, she's not getting a spinal, but she is getting a nice block so that they can manipulate if they need to. And if she has a third-degree episiotomy, there's a lot of sewing afterwards, and you really want to have a little bit of anesthetizing there in order to sew somebody. Yeah. So that's nice. The epidural is going into the epidural space, as you all know. What do I have to worry about with an epidural?
Loss of feeling sensation or something like that.
Yeah, and those kind of questions fall under safety and risk factors for a woman having an epidural, such as, she just can't feel anymore from the waist down. So you don't want to get her out of bed right away, do you?
No.
You always make sure that after delivery, you have sensation. So what else do I have to worry about with an epidural?
Don't you have to monitor blood pressure?
Yes, monitor blood pressure, absolutely. Because an epidural can decrease mom's blood pressure significantly. And if that happens, then fetal heart rate will go down. So what can I do prior to that epidural being put in that could help with that? Fluid. Yep. You can give an IV bolus. And you would, so you call the doctor and you receive an order for an epidural, and her blood pressure was like 110/70. So he'll say, oh, go ahead, Jessica, and give your patient 500 ml of LR bolus. Okay, so you're going to give her a bolus in order that her blood pressure doesn't bottom. Okay, and therefore then the baby stays good. What do you have to do during the time she has an epidural that she doesn't move, right?
Wait, what?
Okay, she's sitting up for an epidural. What's your nurse's role at this point and make sure she doesn't move?
Right, isn't she like right there to hold her still or
yeah, hold her still, right?
Put on her shoulders.
Yeah, have your shoulders down, right? Make sure her shoulders are down. Her lower part of her back is pushed out to the anesthesiologist. Okay, and I always tell my patients, don't move. And I'll say, okay, now you're gonna feel a little pinch because that's the xylocaine. And then, because they'll numb the area where the spinal needle is gonna go into. The more that you coach your patient on this and you are preventing her from moving, thus saving her from getting a what? Spinal headache. Okay, okay. All right, so we're gonna get into the epi space. All right, she's anesthetized from the waist down. What's the best time to give an epidural? Or maybe the optimal time?
Between 4 and like 7 centimeters in between there.
Yeah, what phase is that?
The second.
Second.
No.
First
That's the
stage.
first.
First stage.
No, listen to what my question was. What
Phase.
phase?
The phase. That's the
Oh,
late, not
phase.
latent. No, not latent. It's active. No, active phase.
Active phase.
Okay.
Good, good. You brought it back. It was in the brain and you brought it forward. Okay, so that's the active phase. Yeah, that's a good time to give an epidural. Okay. If your patient wants a narcotic, what's the optimal time to give a narcotic? Okay, I put it this way. Which phase would you not give a narcotic in?
During labor.
Phase 3.
No.
The last
Second,
one.
Okay, what's that last phase called?
The recovery phase.
Transition.
Transition. Whoever said transition, absolutely. Okay, yeah, you don't give a narcotic during that time because your baby's going to come out. Because don't forget, the narcotic will go right across the placenta, and that's called transplacental, and it goes right over the placenta right to baby, correct? So the baby comes out and he's going to be like sleepy. He will have a lower Apgar because you gave a narcotic. What would you have on your radiant warmer if you needed to reverse that?
Narcan.
Narcan, naloxone.
Yes, right. And you see, you know both of those. Okay, good. Okay. All right. Very good. All right. Spinal. All right. Tell me about a spinal. When do we use the spinal?
C-section.
Yeah, mostly for C-sections, right? Epidurals are so good for our laboring patients. Spinal for C-section, or maybe even emergency C-sections. I'm thinking about maybe coming in also. Be both elective and emergency. Same thing. If she gets a wet tap, say unfortunately she moved, and she's got a terrible headache, right? You give her caffeine. You give her Percocet maybe even, and you give her and nothing's helping these spinal headaches. What can be done to help her?
We have to put the blood back into that hole.
Right. What's that called?
A blood patch.
Blood patch. Good. Okay. We're going to do a blood patch. So you take her own blood, 10 mLs of her own blood. And this is all very, very, very sterile, guys. And so then we're going to sit her up like she did in the beginning and go right into the same area that either the spinal or the epidural was placed, and put that little blood back, put her own blood back in, and that creates like a blood clot. And bam, wham, your headache is over. Okay. Then she loves you.
Why wouldn't they just do that to begin with, so that they don't have to go through all that prolonged other stuff and just get it done immediately?
Because remember, we always go with the least invasive to the most, right? Like we offer a bedpan before we catheterize, correct? So we go from least invasive to the most. Okay, so we'll try with all the others. Maybe just giving her fluids, giving her some caffeine can help it. But they go home, a lot of times they're actually home and they come back into the ER because their headaches are so bad. Okay, so we went over non-pharmacological methods of handling pain and labor, and we've gone over epidural, spinal, and pudendal block. Okay, all righty. Let's move on, and then we'll take a short break in a few minutes. Okay, so let's go into another area that they like to categorize things in for HESI exams. And okay, you're going to find this when you start studying for NCLEX too. Psychosocial integrity. So how does the woman adapt to her new role? Okay, we talked about that many weeks ago about adaptations to pregnancy. Remember that? How she adapts to a new role, assessing the parents' interaction with babies, the parent bonding issue. Those all can fall under psychosocial integrity. So if you think about bonding, how does the nurse promote bonding?
Skin to skin contact.
Skin, kangaroo.
Okay. Holding the baby, right? In face we call it ENFACE. Holding the baby, talking to the baby. How about talking to the baby?
Yeah.
Yeah. I think I heard skin to skin. Yeah.
Yes.
That's the kangaroo. Yeah, really important. So breastfeeding. Oh, that's my best. Breastfeeding, absolutely. And getting back to postpartum hemorrhage, you have a patient that just delivered, and you see a lot of bleeding, and you've got her massaging the fundus. What else can I do to maybe release more oxytocin?
Breast milk.
Yes, put that baby to the breast. Right. Okay. And that's why I tell you, after delivery, it's so good. Baby comes out, we dry the baby up real quick, and we put the baby right on mom's chest. And mom can, we can all dry the baby. You can do APGAR score during that, and you're already promoting bonding. And then after that, you can put the baby to breast and use a win-win situation, is it not? Okay, all right. So I'm gonna guarantee that there'll be a question about APGAR, okay? And what there'll be like a scenario, and you have to know what the nurse should do. So I put down here some things to remind you. From score of 7 to 10 is good. So baby's wet, right? So what are you gonna do? You still gotta dry the baby, right? Because what am I worried about right in the delivery room? What am I worried about?
Respiratory.
Yeah. Right. And respiratory, and even though he got a good APGAR, he's wet and he's cold. So let's get him dried off, because I'm thinking thermoregulation, right? Right. So let's get him dried off, get him all snuggly in a dry blanket, put a hat on him, and make sure that he's not in a draft, and that you can promote the bonding and breastfeeding. Now the baby has a score of 4 to 6. He needs a moderate amount of resuscitated efforts, okay? Moderate amount. Maybe you got to take your finger and slap him on the little sole of the feet. Okay, it's time to come around. Needs 4 to 6. And then 0 to 3, guys, is severe. And you need to have resuscitation methods in there. Now, in your HESI book, they have a really good outline of the APGAR score. So be sure, if you're not good with the APGAR score, you need a little bit more, use your HESI book. All right, so what happens when a newborn experiences respiratory distress?
Their chest sinks in, retraction.
Yeah, you see those little sternal retractions, maybe intercostal retractions.
They start grunting.
Yeah.
They start to grunt, and their nose starts to kind of flare.
Yeah, flaring of the nose, there is, yeah, grunting, yeah. What kind of color do you think he's got? I don't think he's got good color, do you think, Jacob?
Dusky. No, he's gonna have a really pretty dusky, very pale color.
Right. And then tachypnea, right? Greater than how many beats per minute?
60.
Yeah, 60. Be sure, I know I told my class, but be sure to know the normal vital signs of a newborn. So if you know this is for NCLEX also, for HESI, everything. If you know the normal vital signs, then you can pick out the abnormals. That's the saying. Okay. So don't forget respiratory distress. Respirations is the biggest job these babies have to do when they're born. Okay, so we want to keep them warm. I think I've said that already. Okay. All right. Then another area that they always like to hit upon is grief and loss. Okay. And so how does a nurse talk to somebody who just had a stillborn?
Empathy.
Well,
You let them talk to you. You just kind of listen.
yeah, you do listen. You let them talk if they want to talk. Okay. When you're talking to someone, you always want to have what? Good eye contact, right?
Eye contact and like a reassurance.
Yeah, reassurance. And I'd be careful. Some folks say with the reassurance of a touch, but I put this in there on my slide because some patients don't want to be touched. So I always ask my patients, and I asked them in the beginning when I first meet my patients, would you like to be touched or not? And they'll tell you right away. Okay. This is a memento box. What do you put in a memento box for somebody who's just lost a stillborn, just had a baby?
Maybe like their ID band,
Yeah.
ID band, maybe like their hat, just things
Yeah.
that is gonna keep them like
brands.
have something to remember them by.
Right. That's great, Jacob. Yeah, I heard footprints. Yes, footprints. Sometimes we even do handprints. Sometimes moms will let us know if they want a little lock of hair. We get permission to do that. But you always ask. What else might think about? The little bands. Oh, how about a picture? You can do a picture. Nurses become very good. Years ago, we used to do our own pictures. In some hospitals today, the really expensive hospitals today, they have people coming in doing pictures, but nurses still do pictures. And what we want to do too, if a baby has been expired for a while, sometimes the head is caved in. So when you're going to let mom see the baby, you want to cover the head. Okay. And you want, and you take a picture, I always take a picture from the better side. You want to make sure that you get the good side, because these are mementos that mom's going to remember. Okay. All right. And then it's not an easy thing, not at all. And you always want to use what kind of communication? Right, open-ended, right, therapeutic, right?
Open-ended questions, yeah, like therapeutic communication.
Yeah, okay. So that's a pretty long. They usually have at least one question about that. Okay, that's good. You're doing good. Okay, and under physiological integrity, these would be like questions about giving medications. So, in your Sandra's book, last chapter in maternity, there is a whole chapter on medications. So during this past 10 weeks, you've gone over several. We definitely know about magnesium sulfate. So the question could be, does the nurse actually recognize that the patient's having side effects with the medication? So what could happen if you're giving magnesium sulfate?
Seizure.
Seizures?
Seizure.
Well, we're giving that to prevent a seizure. So what does magnesium sulfate do to the central nervous system?
It relaxes it, so you could go into cardiac arrest.
Right. So what reflex can you lose first if you get magnesium sulfate toxicity?
Here, is that the hearing?
No, hearing is actually the last to go of anything, but reflex. Okay, so you lose your what? reflexes of your knee reflex. So they come in, and how you know they were hypertensive too is because they were what? Maybe they were hyperreflexia on a mission, like 4+. And now you do your assessment checks, right? Because she's on MAG. And so you test her knee reflex and you can't elicitate anything. You got a problem? You got a problem. So when you lose reflexes, which you can do with magnesium sulfate, that's called magnesium sulfate toxicity. Okay, so what do I do? What's a nurse do?
It's that, what is it? It's
calcium gluconate.
oh, yeah.
Yeah, yeah, you're going to have that at bedside. You have calcium gluconate, and that helps to bring down, to reverse it. I also will get a magnesium sulfate toxicity level 2 on this lady. Also, I'm going to call a physician. And then, of course, you have your calcium gluconate. So in order to answer those kind of questions, you'd have to know about magnesium sulfate. So when you're studying these drugs, okay, you not only want to know why you're giving them, but also know what side effects. So, and also you want to know when a drug is like contraindicated. They love that word, contraindicated. So like example, Methogen. Would you give Methogen to a hypertensive patient?
No.
No, because we know Methogen what?
Well,
Increases the heart rate. Right. Yeah. Okay, good. Okay. So that's how you would have to be able to answer those type of questions, is that you would have to know the drug. Okay. Okay. So you want to know the drugs for what? Postpartum hemorrhage. And you want to know your tocolytics. And you want to know your pain drugs. Okay. There could be a question like on monitoring results of either maternal fetal tests, maybe results of NST. What's an NST?
A non-stress test.
Right, right. What does a non-stress test do? What does it signify to us?
The baby's type of fetal distress at all in there?
Yeah, it's fetal well-being, right? So a non-stress test is a non-invasive test. It's an easy test. You put the monitors on mom's belly, right? She's hooked up to electronic monitoring. You give her a little buzzer. And when she feels the baby move, she presses the buzzer. So what I'm looking for is 2 accelerations of the fetal heart rate correlating with fetal movement. So for instance, I got a 20-minute test, because that's how long I have to run this test for. And in 20 minutes, I got to get 2 movements with accelerations. So if I got a fetal heart rate, say of 120, and baby moves, she presses the button. With that, you see the heart rate. You see the heart rate go up to, say, if it's 120, say it goes up to 140, and it lasts 15 seconds. That's great. So the acceleration has to be 15 beats above the baseline, lasting 15 seconds. That's your NST. And it does, it tells us that baby is, hey, I'm doing okay in here, guys. That's how babies talk to us, is through their monitoring, through their fetal heart rate. So baby's saying, I'm okay. My heart rate went up to, say, 135. I came down and I'm back to 120. I got moderate amount of variability, which means I'm in good shape. Do I have a good test? I have a reactive. That's called a reactive test. Now, your test is non-reactive when baby, even though you try moving them around stuff, he just doesn't want to move, or he has no accelerations. So you don't see any accels. Mommy may feel movement, but baby's not, his heart rate's not changing. That is a non-reactive test. So that's not good. So then we would go on to do a biophysical profile. All righty, so fetal surveillance tests are used with our high-risk patients, such as patients that are preeclamptic, or diabetics, immune problems such as lupus, maybe mom has thalassemia. We're going to do an NST. Okay, and another question too, a lot of times you have to be well prepared for is about post-op care. Patient has a C-section, okay, and so what do you worry about in the recovery room?
Possible infection, and hemorrhaging.
Hemorrhaging, right. And two, I want to make sure that the sutures or the staples are, intact, that they're not seeping. So I got a big old bandage on my patient, okay, and so I see, Jacob, I see a little bit of drainage on the dressing. What are you going to do?
Monitor the dressing monitor the discharge to see if it's like a pussy yellow or if it's just normal, just discharge, and then you'd want to contact provider and everything to have them redo the patch.
Yeah, well, what we do is, so I see a little drainage, so I take a little pen, I just put a little circle around it. Then as I'm doing my vitals and I'm assessing her fundus and I'm looking at her lochia, because it's lochia rubra, right? I see a little bit more. I see that seepage now going outside my little circle. Should I be concerned?
Yes.
Yeah, I'll be concerned because that means that she's either bleeding or something's happening underneath that bandage. And like you said, call the provider because they'll either give you an order to remove the dressing or they'll say, I'll be right in. I'll come back. Because a lot of the surgeons like to remove their first dressing. I don't blame them. So when you have a C-section, are you massaging the fundus?
Yes.
Yeah. Don't you have to be worried about a boggy uterus even with a C-section?
Yes.
Yeah. More so even sometimes, especially if there had a C-section for maybe multiples. Maybe she had quads, which are 4 babies. And so that would cause that uterus to be distended. And so after everything, all the babies are removed, that uterus is probably saying, okay, I've done my job, I'm checking out. Okay. And so it becomes soft and boggy. And she can hemorrhage just like any other delivery. So yes, you do. Granted, we do have a cesarean, we do have a scar, we have not a scar, but we have an incision. So we're going to do it, gingerly, but we want to make sure that she's firm. What else during the post-op care are you concerned about?
We already said a hemorrhage, right?
Yeah, so we're about hemorrhage. I'm monitoring her blood pressure, right? What else am I watching?
The incision.
We said about the incision. Okay, what else am I concerned about?
The DVT.
She said DVT.
Not yet though, but I could be thinking, DVT. What else? I'm in the recovery room. What am I making sure is draining down to gravity?
Urine.
Urine. Yeah, the Foley. Okay. Yeah. Make sure that you're looking and doing INOs. If she had a general anesthesia, what do you have to worry about?
General anesthesia?
Yeah.
How
about the old fashioned? Cough and deep breathe. Cough and deep breathe. Take it. Mrs. Jones, give me a good cough. And what do? I give her a little pillow to put over her incision and give me a cough. Take a deep breath and give me 3 good coughs. And I explain it to my patient because a lot of times they'll give you a cough like, huh, huh, huh. Well, that's not going to do anything to get any fluid out of your lungs. So what do? I tell them to take a deep breath, give me 3 coughs. Like if you were a patient that has smoking for 40 years, okay, give me that kind of cough. And they give me good coughs. Okay, that's for general anesthetic. And that's for a patient in med surg that you're going to take care of after having general. All right. So if you're not too sure about your post-op care, go back and look at that up in your HESI book. All righty. Let's see. I got one more. Oh, that's it. I'm going to give you a break now. It's perfect. It's at 4:06. When you come back, I want to go over first before I do anything. I got some questions I want to ask you. See how good you're doing on questions. And then I'm going to try to cover postpartum complications. All right. So I'm going to stop sharing. Okay. So the time is 4:06. How about a 10-minute break? Now I have somebody I see here on iPhone. What's your name? Put your camera on, please. I don't want to remove you, but I will have to remove you if I cannot identify you.
I got a quick question before I leave for our little break.
Okay.
Is the PowerPoint that you just was going over, is that going to be available to us in the modules?
Yes.
Okay.
Always. Okay. Who's on iPhone so I know who it is so I can give you credit? Otherwise, I can't give you credit for attendance.
I'm sorry, Miss Dunham. Will those PowerPoints also be available for Dottie's class, or is it just for your class?
Oh, sure. No, it'd be for both classes.
Oh, okay. Thank you.
You're welcome. Okay. iPhone person.
Alicia, I think that's you.
Oh, is that me? I'm sorry.
Yeah.
I'm sorry. It normally comes up my name. My name's Alicia. I'm trying to figure out how to go change it.
Okay. Go. I'll tell you how to change it. Let's see.
Can we go take our break then real quick?
Yeah. Yes. Okay. Go. Take a break.
Okay. We can shut our cameras off for the break too, right?
The cameras can be off, but don't come off Zoom. Because that will break your attendance.
Yeah, I don't know how to change it.
Okay, write your name in chat and I'll go ahead and put it in.
Okay, thank you.
You're welcome.
Sorry, I didn't know you were talking to me.
That's okay. I don't know you, so I couldn't say you.
Okay.
Communication is a lot different online.
Members, Scott Smith, seemingly vanished from reality, there were lots of questions. Back in November of 2000, after playing with his band in Vancouver at a benefit, Smith, along with two other friends and his girlfriend, set sail for Mexico.
Oh, my goodness.
Sailboat. As they were sailing down the coast nearing San Francisco, the weather started to get rough and the waves started to get dangerous. Then,
my goodness, what is that?
20 feet in size, knocked over.
Okay, I think I found it. Sounds interesting.
Ms. Dunham, I have a question.
Sure. Hi.
Okay, you know how we were talking about their Gravita, like GT Palm or whatever? Yeah. And I was doing the practice questions on the HESI and CLEX one that we can put in study mode.
Yeah.
And I had one that came up and it was about the GT Palm and how it said that she had an abortion. And you know how it said that the lady had a miscarriage on this one? They're not counting that as an abortion, right? Because when you read in the book, it says that an abortion, also like a miscarriage, is kind of labeled as that.
Yeah, well, this lady on this situation, for preterm, it was the baby made it to 22 weeks, so it went past viability.
Because it says that it was still an abortion, like if they lose it, so it's not counted that if it's past viability.
Yeah, past by 20 weeks. Yeah, and it's right in HESI. Let me guide you. Let me see here. Page 181 in your HESI book. It goes into the 5-digit GTPAL.
Yeah.
Yeah. And once you count it as a preterm when it gets past 20 weeks.
Okay.
Yeah. Just don't forget the present pregnancy. Okay?
Thank you.
You're welcome.
Jessica, you see what I sent you?
Yes, girl. Did you see what I sent you back?
No, hold on.
Because I wasn't even doing that. It was after the fact. I went to go down to check my daughter. I went to go get her vitals and everything to see where she was at, and everything was good. Like her blood pressure's back up, her eyes are good. She got a little bump on her head because she hit the wall on her way down.
Oh.
But she's okay. Like I mean, everything's normal. She just got up too fast, but she also has her bleeding disorder. So sometimes can't do anymore. She's on her medication. She does, what she needs to do. But she was like, Mom, you were in class. I didn't want to bother you. I'm like, I don't care if I'm in class. I don't care what I'm doing. No, the world stops.
Of course. How old is she?
She's 14.
Okay.
Yeah, she's not little, but I mean, I understand and I respect the fact that she knows what this is, but at the end of the day, you will always come first.
Oh, of course. My son had 2 bleeding disorders.
Really?
Yeah.
We didn't notice anything. We didn't ever think anything of it because we lived in a dry state. So she constantly would get like nosebleeds, but that was very normal for where we lived because it was so dry all the time. It wasn't until she started her period a couple years ago that we started noticing this isn't normal. It was like a floodgate just completely open. There was never getting regular normal. It was just from day one and just constant, and it was really bad. And so she goes to a hematologist here, a pediatric hematologist, and we go through the whole thing with her to try to as best we can to maintain it.
Sure. My son had idiopathic thrombocytopenia purpura, almost like a hemophiliac. And also had another one, antiphospholipid syndrome.
I know that they tested her because I know she's missing a clotting agent, 1 out of the 11. But when she was tested, it wasn't the von Willenberger's disease.
Okay.
She's not a hemophiliac. And they're able to actually fix this with, she takes a medication. It sucks she has to take, but she has to take 5 pills every 8 hours while she's on her period to help control the bleeding. She'll have to take it the rest of her life.
Yeah. It's a lifelong situation. Yeah. I can empathize with you on that one. You always worry. Okay, everybody coming back? All right, let me see y'all's beautiful faces. You see mine? Let me see yours. Okay. What I want to do, for just a few questions, see how you could answer the questions. If you know the answer, put your hand up. Okay, so you know your reaction button, right, everybody? Everybody got a reaction button. And on the reaction button, it gives you a choice, and then you put your hand up. Okay, so let me try this. I'm trying something different today. Let's see how it goes. Are you ready? Now, if we were on campus, we could have a little contest. But anyway, we're not there. Okay, so the first question. The nurse is assigned to care for a patient who is in early labor. So when collecting data from the patient, when you're doing your assessment, what should the nurse check first? Okay, Ms. Sidbury?
Is it fetal heart rate?
Yes, fetal heart rate, good, fetal heart rate. So if you thought anything else, right? How about after she breaks her bag of water, she's got spontaneous rupture of membranes. What's the first priority? Same thing, fetal heart rate, okay? All right, because why are you worried about the fetal heart rate?
Distress, the baby being in distress.
Right, and when she breaks her bag of water too, you don't know where that head is, right? The station of the head. It could be up high. So what complications is related to what am I thinking? What complications related to deceleration?
Umbilical cord.
Thank you. Thank you. Okay. All righty. My next one. You ready? The nurse is caring for a client who is in labor. So the nurse rechecks the client's blood pressure and notes that it has dropped. To decrease the incidence of supine hypotension, the nurse should encourage the client to remain in which position? Okay, Jacob.
Semifowlers?
Nope.
Left bilateral.
Mildred.
On her side, don't you got to put on the left side?
Yes, left side. Good. Okay, good. Sideline, right. Okay, good. After a precipitous delivery, the nurse notes that the new mother is passive and only touches her newborn briefly with her fingertips. The nurse should do which to help the woman process what has happened. So what should you do? Do you encourage the mother to breastfeed soon after birth? Tell the mother that it is important to hold the newborn? Document a complete account of the mother's reaction in the birth record? Or support the mother in her reaction to her newborn? How do you think she feels after precipitous delivery? Jessica?
Exhausted.
Right, she's exhausted. So what would you do?
Oh, I'm kind of torn. You want her to breastfeed, but you also want to encourage, like you want her to feel not judged because she's not being so with the baby, but you want her to feel like you're there for her and you're supporting her.
Okay, I like that. Christina, what do you think?
Support the mother's reactions.
Yeah, support, right. You were getting there, Jessica. You did good. Okay. Thank you, Christina, for helping her out. Okay, how about this one? So a prima gravida. So in order to answer this, you would have to know what the definition of that is. Her membranes rupture spontaneously. What action? Oh, here. We already did this. What action should the nurse take first?
Listen to the heart.
Yeah, thank you. All right. So which findings indicate to the nurse that placenta separation has occurred? So you know, when the placenta is coming out, what do you see?
Blood. Bright red blood.
Okay, what else you see? What do you see? The lengthening of the umbilical cord, right?
The cord lengthening.
Okay.
Ava.
Yeah. Well, what's Ava?
Artery.
Two vein, two artery, and one vein.
Okay,
arteries and one vein.
And what else can happen? So we got lengthening of the umbilical cord. We got a spurt of blood. Blood's coming out, right? So I know the placenta is starting to come. And what else? And you actually see the fetal membranes coming out, don't you not? Okay, all right. I'm going crazy. What's happening here? Okay, hold on.
Can you state that question just so I can hear the way it was stated, so I can remember?
Right, because I'm
because that was
I'm like, okay.
I was like,
yeah, you got it. I do anything for you guys. Okay.
Thank you. You can read like the question and the answers. I think I'll get it.
Hey, you ready? Got your thinking cap
I'm sitting
on.
over here. I'm confused. Like, okay, say it again.
Okay. So which findings indicate to the nurse that placenta separation has occurred? So this is like an all that apply question. So when you're seeing the placenta coming out, you would see the cord, the lengthening, the cord itself gets longer because the placenta is starting to come off the endometrium. And so now you would see the cord actually get longer. Okay. You would have a sudden trickle or some splurt of blood, okay, or gush. And then fetal membranes are actually, you can see the fetal membranes coming out. Okay.
I think I was going into abruptio placenta at first.
I was thinking the same thing when she was talking about that.
Yeah, I think that's where we were taking it to when it
I
says.
know, but that's not what question
Yeah.
asked.
So delivery of the placenta is what we're going for. Okay.
That's okay. I'm glad you got your thinking caps on. Well, now that we're talking about placenta abruption, tell me all about it.
A hard bitch's stomach.
It's painful.
Painful,
Okay.
hardened, blood.
It's painful, right? Why is it so painful?
Oh God, hang on.
Well, the uterus just attached from the wall, so it'll.
It's
uterus, but
erupting, right? It's
placenta
painful.
just detached from the wall. Yeah.
You got what, dark red blood, right?
Mm-hmm.
Okay. What causes placenta abruption? Well, what could be a contributing factor?
Trauma, an accident, a fall.
Yeah. Yes. Very good. Okay. Are you ready for the next one? All right. So the nurse is assigned to assist with caring for a patient who's just been admitted to the labor unit. Okay. And so the client, get this, she's 9 centimeters dilated. And okay, whoop whoop. Okay, we're in transition, are we not?
Yes, we are.
Okay. And she's experiencing a precipitous labor, which is the priority nursing action. Now I'll give you the choices. Is it prepare for an oxytocin infusion?
Nope.
Is it to keep the client in a side lying position? Is it prepare the client for an epidural? Is it encouraging the client to start pushing with the contractions?
I'm gonna say the first one, because if it's it's fast, it's fast.
Yeah, I was gonna say you would want to probably get ready to administer oxytocin.
Okay, but which one is a better answer?
The last one.
4.
The last one.
Number 4.
No, you don't ever push at 9 centimeters.
Oh, on her
Oh,
side.
10
on her.
You only push when she's 10. Yeah.
You would want to go on her side and everything, because if not, the way how fast the delivery is happening, it would kind of be able to prevent possible hemorrhage and perineal trauma.
Hematoma.
Mom, go to the bathroom.
I like that, Jacob. I like that. That's good. Okay, yeah, I put her on her side. Yeah.
That's what I'm telling you.
But probably the fetus, Elizabeth, probably the fetus needs some more oxygen, don't you think?
Yeah, or that I said hemorrhage, but yeah, the baby's gonna end up needing more oxygen and everything.
Yeah.
Because how
So I
fast
put her on her
she's
side.
contracting.
Yeah. Because we don't want her. Now, do you think she's gonna have an urge to push?
Yeah.
Yeah.
She'll have an urge to push because she can, but you don't want her to push. You only let them push when it gets to be 10 centimeters. And the reason why, guys,
Girl, come on.
hello, is the reason why you want to wait for 10 centimeters is because the cervix could get edematous. Okay. All right. And once you get a cervix that's edematous, it's never good. Okay.
But you can dilate to 10, but that doesn't mean you're fully effaced, right? Like sometimes your cervix won't thin out enough.
No, if you get to 10 centimeters, that cervix is effaced. Yeah,
Okay.
it's nice and soft. It's like paper thin. You can't even feel it anymore because it's all gone now. Beautiful. Yeah. That's when you take your 2 fingers and you go around and you go, ooh, it's all head here. So I go from, okay. All right. You have to go like, you check and you go, okay, no cervix here, come around, no cervix on this side. Okay, you're 10 centimeters, push. Okay. And if I start pushing, what stage of labor am I in?
3rd.
Nope.
In the
You're in 4th stage of labor because that's homeostasis, right?
Nope. No.
Second stage.
Wait, are we still in the question before? Which question we on now? New one?
Right.
I just gave you a new question.
Oh, I didn't hear it. Sorry.
What
I thought
stage
we
of
were on
labor
the
are
last
we in
one.
when we're pushing?
Okay, so if I'm pushing, what stage of labor am I in?
It's the second.
2nd.
Thank you.
You're
Thank
in the
you.
second.
Okay, good.
Oh,
All right. So if you don't know those stages, like the back of your hand, Go over that. All right. Because what happens in these questions, they're going to give you a scenario and you really have to know what stage and what's going on. And so you can answer them properly, right? Okay. All right. The next one. Is this helping? You like this?
Yes.
Okay. All right. The client is admitted to the labor suite and she's complaining of painless vaginal bleeding. The nurse assists with the examination of the client, knowing that which routine labor procedure is contraindicated.
Vaginal exam.
She don't want to put her fingers up there.
Thank you.
Yeah. All the vaginal exam.
I love it. I'll take it any way you want to give it, but I know you don't put your fingers. Never. No, because she's coming in with painless vaginal bleeding. Okay. How about this one? You get this one now. Come on. The nurse is assigned to assist with caring for a client with abruptio placentae who's experiencing vaginal bleeding. So the nurse collects data from the client, knowing that abruptio placentae is accompanied by which additional findings. So what findings would I see if I have a placenta abruption?
A rigid stomach.
Yeah.
A hard stomach.
Pain.
Very painful.
Painful, rigid, board-like, those descriptions, right? Very good. Okay. The next one, let's see if we get this one. How about this? So the nurse is collecting data from a client who has been diagnosed with placenta previa. Which findings should the nurse expect to note? What would you note on a placenta previa? Would it be uterine rigidity? No. Uterine tenderness?
Yes.
Placenta previa. Severe abdominal pain?
Oh, no.
Good. Bright red vaginal bleeding?
Bright red vaginal
bleeding.
Right. And soft, relaxed, and a non-tender uterus, correct? Yes. Okay, good. All right. And the reason why it's bright red is because the placenta previa, the placenta is laying right across the internal os. So that blood is nice and fresh. Okay, so it's bright red bleeding. Okay, well, we'll do a couple more and then we'll go on to postpartum complications. Let's see. All right, how about this one? So the patient who is being prepared for cesarean delivery is brought to the delivery room. And to maintain the optimal perfusion of oxygenated blood to the fetus, the nurse should place the client in what position?
Left sideline.
Let's see.
But she's in.
So let me tell you. So this question could be a little tricky. So let me give you the choices. She's going to have a cesarean. And so she's in the operating room, say, and we're bringing her back. So what position on that operating table would I put this patient in?
Being supine.
With what?
With legs, the Trendeling position.
Not Trendelenburg. You were right, Jacob, but what else am I going to put there? I don't want her laying on her back. What else could I put behind her?
Oh, like a pillow or like a guard,
or we call it a wedge, a pillow. You know, you always want them on a left lateral tilt. And having cesarean, we put them on a left lateral. So what happens? Let me tell you, in the real world, what happens? We have her on the side. We do have her on a tilt, okay? And we're all there. We're scrubbed in, because I first assist on a lot of cesareans. And so we have her there. And what the surgeon will do is when he's ready to cut, he will remove that wedge and we'll go ahead and cut and baby come out, okay? So we never have her in a real supine position. We have her on like a tilt. And so the question was kind of tricky, but that's what you can expect.
But we'll be seeing like we'll get to choose from one of those answers, right? Like it's not just blank.
So I wanted you to know you're not going to put in Trendelenburg. You wouldn't put in semi-Fowlers. And you don't put her in prone. No prone, please. Okay, so that'd be kind of hard. I thought I'd make you laugh. Are y'all listening to me? Because you should be laughing your heads off with me.
We're on mute.
I should see all your teeth, everybody's teeth at me. Okay, so all right, so you put her on a left lateral with a tilt. Okay, but so you see, those questions can be a little trickier. So you're always going to read the question twice. Take your time, you know, so that you read the question a couple of times, and always ask yourself, what's my saying? Come on, class. What do I always say when you're taking the test?
You'll see it again.
Well,
you'll see it again.
Well, that one's for getting you prepared for the test.
Take your time. Don't rush. It's not a race.
Okay, right. And what's the next one? Ask yourself, what's the question asking me? What's the question asking me? All right. Okay. How about this one? Huh?
I was gonna say, now that I think about it and everything, because I watched your last review for the last exam, and you said that at least 20 times throughout the review. Yeah. No.
Yeah. Okay. So you always want to give yourself time, and you're never in a race. Okay. You want to watch your time, of course, but you know, some people, they fly through these things because they're not reading them. And then when I go over with them, they find out, oh, what did I answer that one like that for? I don't know. You tell me. Okay. All right. So let's go on. A woman in active labor. Oh, she's in active labor. And she's having contractions every 2 to 3 minutes. And these contractions are lasting 45 seconds. So the fetal heart rate between contractions, 100 beats per minute. Okay, so that's a resting tone. On the basis of these findings, which is a priority nursing action? All right, so what would you do? So would you monitor the maternal fetal signs? Notify the registered nurse, because you're the nurse in the room. Notify the registered nurse immediately. Continue monitoring labor and the fetal heart rate, or encourage relaxation and breathing techniques.
You said them with them contractions are 45 seconds long?
Yeah, and they're every 2 to 3 minutes. The fetal heart rate is 100 beats per minute.
Oh, that's low.
Low. Good. So what's that called?
Bradycardia.
Yeah.
Yeah. So what are you going to do? You're the LPN in the room. You're helping me out. What are you going to do?
Can you read the answers?
RN.
I'm going to call them.
Who said that? Who said get the RN?
Notify the RN.
Yeah.
I did.
Everybody said that.
Okay. You got it. That was a good answer. Okay. Love it. You're a team. All right.
Yes, we are.
All right. So the nurse is assigned to assist with caring for a patient who is being admitted to the birthing center. Okay. So she's in the birthing center and she's in early labor. During admission, which actions should the nurse take initially? Oh, that's easy enough. Okay. Estimate the fetal size. Check pelvic adequacy. Administer an analgesic, or determine the maternal and fetal vital signs.
Maternal and fetal vital signs.
Yeah, absolutely. Good. Okay. All right. Our last one. The nurse is assigned to work in the delivery room and is assisting with caring for a client who has just delivered a newborn. So the nurse is monitoring for signs of placenta separation, knowing that which indicates that the placenta has separated. So would it be a sudden and sharp abdominal pain? Would it be a shortening of the umbilical cord? Would it be a decrease in blood? Or would it be a change in the uterine contour or configuration? What would be the best one? That's a good one.
Increase in
It
blood.
should be the change in the uterine configuration.
Yes.
That very last one.
No, who said a change in the uterus?
Tequila did. Yeah.
Tequila, you're right. Yeah, exactly. Yeah. The last one is that would be a decrease in uterine in blood loss. It would be an increase. So that one's X'd. Remember, we just went over that. A shortening of the umbilical cord, it would be, you would X that one because it's getting longer.
Right.
Yeah. And sudden and sharp abdominal pain, no. They shouldn't have that sudden and sharp pain. They may feel a little discomfort, but they usually, when you deliver the placenta, it's like delivering another baby. You just push it right out and it's out. Okay. So I hope you enjoy those kind of questions. And let's go back. And we got some time left to do postpartum complications, because just last semester, there was 5 questions on postpartum hemorrhage. Okay.
How many questions is on our HESI, Ms. Dunham? Is it 55?
Yeah, 55. Yeah.
No math, right?
Oh yeah, there's math.
Oh, they do math on that? Okay.
Yeah. Oh yeah. They have a couple like PO. There may be an IV, so you want to probably do that. I know, guys. They like weighing the diapers. You know. All right. So you know that because you had that on your doses calculation worksheet. All right. All right. So let's go ahead and let's discuss about postpartum. When you do a postpartum assessment, what's the acronym that we use? So it kind of keeps you going. It's called Bubble HE. Bubble HE? Okay. It's called Bubble. B-U-B-B-L-E-H-E. So write down B U B B L E and then H-E. All right. So what we're going to look for, so we're looking at our postpartum patient. So this is what we're going to assess.
Breast.
We're going to look at her the first B is what?
Breast.
Okay, good. The U, what we have to worry about?
Uterus.
Uterus.
Right.
For the breast?
For breast.
Is it just me or is her computer like freezing up?
Okay, I thought it was just she
Wait,
like
wait.
vibrating, gyrating all over the place.
Wait.
Gyrate.
Am I okay?
You're fine. I think someone else is being back.
Every time you, I don't know.
Yeah, she was like
No, she was
freezing or
freezing.
sort of speak.
It was.
You're like skipping.
Yeah, and freezing.
Yeah, freezing and skipping and.
How am I now?
Okay.
Okay.
Wait, but look, do y'all see where
is she showing up on two people?
Yeah, she's
things
showing
whenever
up
she
on.
talks. Whoever talks, you show up on that CHEDLY person screen.
That's Shedleen. That's Shedleen. Shedleen needs to shut her
put
camera
myself.
off and turn it back on.
Yeah, shut yours off, Shedleen.
Yeah, I put myself on mute.
No, you have to. No, you have to turn your Shedleen. Turn your stop your video.
Turn your camera off for a minute. Turn your camera off.
Okay.
Okay.
What in the world?
Yeah, it's called technology.
Yeah, stop video. Down the corner.
Okay, shut your camera off, sweetheart. Yeah.
Sorry, I was just confused. I didn't know if that was your camera or somebody
That's
else's.
okay. All right, let's move on because we got stuff to cover because next week is your HESI. Okay, so bubble heat. First B is what? Breast. The U
Breast.
is you're looking at the uterus. This is your assessment of postpartum. The next B is what? What you have to worry about?
Bladder.
Okay,
Bladder.
bladder. Okay, what's the next B?
Bowel.
Bowel. Okay, what's the L?
Lochia.
Lochia. Good. Okay, what's the E?
Episiotomy.
Good. Okay, what's the H?
A Holman sign.
Holman sign.
Yes. And then what's E?
Emotional status.
Yes. Very good. Emotion. Yeah, you got it. So when you're looking at postpartum, that's what your assessment is going to be. So the breasts, so you want to make sure that she has a nice bra on. If she's breastfeeding, you want to make sure the baby latches on properly. I don't want my patient to get mastitis, so make sure that baby latches on to the entire areola. Okay. She can wash her breast with water, let it air dry, and wear a nice, comfortable nursing bra. Good. The next, when we're looking at the uterus, we want to make sure the uterus is nice and firm. Okay. We do not want a soft boggy uterus. The next B is bowel. So make sure that she has a bowel movement, because then we could increase her fiber if we need to, increase water intake, get her up walking, will all stimulate the bowel to operate. A lot of ladies, especially if they have an episiotomy, are very scared of having a bowel movement. Okay. What's the next one? Lochia. No, bladder. Bladder? Yeah. Okay, bladder. Then make sure she's voiding. Now, when she urinates, you want to make sure that you teach her how to do pericare. Every time she goes, she's going to do pericare. Okay. The next one is L, lochia. So it'll be lochia rubra for the first couple days. Then it goes to what? Lochia serosa, and then it goes to lochia alba. Okay, so we're going to assess her lochia, because if she's having a lot of blood and she's passing clots, is that good? No. So we want to assess and make sure that her bladder's empty and her uterus is what? Is firm. Okay. So next one we're talking about is what's the next one?
Episiotomy.
Episiotomy. So what's the acronym for episiotomy?
Is it Rita?
No, it's that Reba.
Rita. Yeah. So what's the R? Okay, in Rita, REEDA. Put that down on your notes.
Yep.
Redness.
Red.
Okay, redness. And what's the next E?
Ecchymosis.
Okay,
Edema.
I'll take edema. Okay, what's the next E?
Ecchymosis.
Ecchymosis, right? What's the D?
Discharge.
Yes. Okay, good. And what's the A?
Approximation.
Yep.
Good. Okay. So when you're looking at questions that concern that, you want to take in consideration what you're looking at. Okay. Does that help you? And then H is for the Homan sign. Is a positive Homan sign good?
No.
No, never good. What does that mean? Well, what could it mean?
That could mean she could have like some type of blood clot or DVT.
DVT.
Yes, exactly. DVT. Okay. Could you just say, "Oh, you'll be fine, Mrs. Jones"?
Oh no.
Absolutely not.
Good.
I'm like,
Oh,
unless
no.
you want your license taken, but that's your opinion.
So what are you gonna do then? You find that she's got a redness area in the calf. She's complaining of pain. What are you gonna do?
You need her to start walking. She has to walk.
Ambulation.
No, if she has one, we don't want her to walk because it could break.
Do you elevate it at the level of the heart?
Well, what are you gonna do? You gotta call the doctor.
Yes.
Okay.
Before it gets worse.
And then he'll probably order a venous Doppler
Okay.
study. You get a venous Doppler study to make sure that either she has it or she doesn't have it. Okay. All right. That's good. Okay. And then E is for what?
Emotional.
Emotional. Yeah. Do we have mood swings after delivery?
Yeah.
Yeah. If I'm just sad? Oh, I'm tired. Just Nurse Jessica, I'm so tired.
Baby blues.
Okay, baby blues. Okay. If baby blues, is that common?
Yes.
Yeah, it's common. Yeah, it happens. But now it's about 2 weeks, and I'm going, oh, Jacob, I just don't know what's happening. I'm so sad.
Postpartum depression.
Yeah,
Yeah.
Yeah. I don't like, maybe I'm not interested in anything. Maybe I lost interest in my own activities, even taking care of myself. That's depression. Now, I say to Alfreda, Nurse Alfreda, oh, I'm hearing noise. I'm hearing people talk to me in my head.
That's like a psychosis.
Postpartum psychosis.
Postpartum psychosis. You're hearing delusions. Okay. And what do I have to worry about on that one?
Suicidal ideation.
Suicidal ideations. And what else?
And fetal ideation.
Yeah,
infanticide. It's called infanticide. Okay. All right. I'm going to share my screen now. And we're going to go into touch on postpartum complications. Now if I can find the screen here, I got so much.
Ms. Dunham, I was kicked out of your Zoom just a couple seconds. I got back on my phone, but
thank you for telling me.
I don't want to get pointed because it cut me off. I got back.
That's what I'm talking about. Thank you for telling me. So when I see the attendance, but for me to mark you down for attendance, I mean, it's got to be pretty significant. When I see a minute or half a minute, we're pretty good. Okay, but I love when you tell me. Makes my job easier later. Okay, let me find my screen here. I have so many different reviews. Oh, that's all my stuff there. Hold on. You like that one? Okay.
Did it have answers? That's what I was looking for.
Well, I'm back again. Oh. Remember this.
You'll see that again.
Yeah. If you remember, oh, that's somebody else. Okay, hold on. What happened to my postpartum assessment? Hold on. I have so many reviews, guys. Let's see. Maybe
take your time.
Oh yeah. Well, I go back in this one to the embryo. Oh goodness. Let's see. Thank you, Patrick. Let's see here. It's got to be, that's not the one. That's not the one. Oh, what did we do? We lose it? No, that's not the one. That's not the one. That's not the one. Oh, okay. Did you all take it from me? There it is. I found it. Okay. It just keeps me, I can be talking. This keeps me on track to make sure that I go over things with you because, I want you to do well in the HESI next week. Okay. So postpartum complications. Okay. So we went over a couple of these already. We already did hemorrhaging and hypovolemic shock. We did, remember hypovolemic shock, going to see what tachycardia is your first sign, right? We got hemorrhaging. If you hemorrhage 500 mLs or greater of a vaginal delivery, is that normal?
Yes.
Not greater.
No, it's not normal. See, that was a tricky question. No. Sorry, Patrick. I think that was a tricky question. But anyway, because I reversed the question. So 500 mLs or greater is a sign for vaginal delivery, is a sign of a hemorrhage. If it's 1,000 mLs or greater for C-section, that's a hemorrhage. Okay. So just know if they have a question about that, you want to know that you can realize that your patient's having
whatever they decided I couldn't do is exactly what I did.
What is that?
Okay, thank you. I don't know. All right. Sometimes I think I hear noises.
Psychosis.
Postpartum psychosis. Oh my goodness, this is wonderful. I just love it. Okay, so here we go to thromboembolic disorders, and that's a clot. SVT, you got what, DVT, and a PE. So we have to be really careful with these blood clots after delivery. And that's why if your patient does have a positive Holman sign, you want to look into that, okay? Because what happens is that a DVT can dislodge itself and move right up into the pulmonary artery, and then you have a PE, okay? All right, postpartum infections, endometriosis, chorioamnionitis, never good. These are ascending infections. That means they go up through the uterus, up in the fallopian tube. Now, chlamydia is one of the worst ones but that's other than pregnancy. Okay, subinvolution of the uterus. What's subinvolution?
The uterus ability to contract back to its pregnancy stage.
Right. It's just it's a delay, right? It's a delay. Okay, it's a delay. So what can cause that delay?
A full bladder.
Yeah, distended.
Okay, what else am I thinking about?
Figure out why, if there's a foul odor coming.
What was that?
What can cause a subinvolution of the uterus?
A distended bladder, or the bladder not being able to pee.
Well, the better question on that would be, it was on your exam actually, is that the uterus is the urinary, how about retained placenta? Yeah, it causes subinvolution of the uterus. When you see a question, it says like, the fundus, the uterus is above the umbilicus and deviated or displaced over to the side. What is the nurse going to do?
Relieve bladder. The bladder.
The bladder.
Yeah.
Right. Okay, good. Empty that bladder. Okay. And they usually have a question like that too. All right. And then we talked about mood disorders already. So we're going to move right on. We already talked, this is really things we already talked about. A hematoma is something I haven't touched on this afternoon. A hematoma in the vagina is very severe. It has what we call unrelenting pain. That means I can give you a Percocet and you're still going to have pain. Okay, it doesn't touch it.
How do they just go away on their own?
Yeah, it's, because a hematoma is a collection of blood. To drain it, they can drain it, but then you're wide open for an infection. So we tried to see if by maybe putting some ice can relieve some of it, and anti-inflammatories to see if we can get that blood to be reabsorbed back into the system. Okay.
So you can give pain medication for that, but it's not going to help.
Yes, exactly. Like I said, it's called unrelenting pain, and that they may use that kind of term. All right. We talked about lacerations. Remember, lacerations is a trickle of blood. And then we talked about uterine atony, soft, boggy uterus is uncontracted uterus. Not good. And then, and that could be too, another reason why she could have that is that she, excuse me, she might get birth to twins, triplets, and the uterus just got over distended. Another thing that can cause that is polyhydramnios, which is increased amount of amniotic fluid. The uterus again gets distended, and so when things are delivered, that her uterus cannot contract. Another thing also that keeps her, can cause her to bleed and have a soft uterus is a placenta previa. Because the placenta is down in the lower segment of the uterus and has weakened that area, weakened those muscles, so it's not able to contract like it normally would. So those are things that can really hurt, can cause that. All right. We already talked about, here we go. Let me go down here. Okay, so here's a question. The nurse is monitoring a client in the immediate postpartum period for signs of hemorrhage. So which sign, if noted, would be an early sign of excessive blood loss?
2.
Yes, very good. 2. Good. Good. Okay, make sure I'm right. Number 2. Okay, good. Good, Jacob. I think you got it. You're going to work maternity, Jacob. He's got it. I tell you what, I'm going to tell you something. When I was nurse manager, I hired lots of men in my L&D. Okay. All right. So, hemorrhage. We talked about this an awful lot. Anybody have any questions about a hemorrhage? Everybody good? Hi, Elizabeth. Put yourself on mute. Put yourself on mute. Okay. And everybody good on hemorrhage and you know about fundal displacement, bladder distension, massaging the uterus. Everybody good? Speak up now.
Yes.
I think we're good. Okay. All right. So here's a question for you. The postpartum nurse is caring for a woman who just delivered a healthy newborn. The nurse should be most concerned about the presence of subinvolution if which occurs.
2.
2. Okay. All right. Because we just talked about that. All right. So if you got uterine acne or atony, uterus without tone, you're going to remember the FFP. You got, make sure that you look at the fundus. If you need to put in a Foley, empty the bladder, and give Pitocin. Okay. Kind of cute, I thought. Okay, here's a question. Okay, Miss Scott, you ready? Okay. So on assessment of a postpartum client, the nurse notes that the uterus feels soft and boggy. The nurse should take which initial action? 3. Yeah, massage the fundus. Good. If you ever remember something, massage the fundus. Okay, here's your postpartum hemorrhage. Here's a great picture of a hematoma. Did you see that?
Oh,
is that painful?
Well, it certainly looks painful.
Yeah. It is painful. Believe me, my patients, they could hardly walk. Now, do you think this lady can urinate?
Absolutely not.
Right. So you'd have to make sure that you're emptying the bladder. If you have to, you have to catheterize her. Do you want to catheterize this kind of patient?
No.
No. Try to put her on the bedpan. Try to put some nice warm water over it. Try to get her to urinate. Is it hard?
I know it burns when she like urinates.
Oh,
I know it must hurt when she like urinates.
It does. What can you do if she's urinating, she's complaining of burning? What could you do to help her?
Compress.
Yeah. You can actually, while she's urinating, she's on the bedpan, you can take your little peri bottle and just pour water over where her perineum there. It helps. Helps take away the pain of the urination, the burning. Okay, we talked about lacerations. We talked a lot in the last couple hours. We talked about hematoma, and we didn't talk about inversion of the uterus. And what that is just inverting the uterus comes out. Okay. I've had a couple patients that happen. What happens is sometimes the doctor says, hey, Nurse Jessica, go ahead and give me some fundal pressure. So she goes on top, and on the fundus, she's pushing down so the head stays down, they can deliver the baby. But that can cause that uterus to come out.
So does that only happen with a vaginal? Because obviously during a C-section, the doctor has to physically take it out.
Yeah, no, it's only during a vaginal. Okay. And if they put too much traction on the cord, you ever see them like the placenta, they're trying to deliver the placenta. And some of the practitioners get a little bit impatient. So they take a hemostat, they start to roll the cord around the hemostat and they're pulling. You see what I'm doing? I'm pulling, right? And they actually too much traction on the cord. Not only does the placenta come out, but the uterus comes with it, and it's never good. Okay, I've had a couple. I had one that we were using the Bradley method, and the lights were off and very dim, and then the uterus came out. I tell you, the lights went on quick though after that one. Okay,
Miss Dunn.
Yeah.
Is inversion of the uterus the same thing as a prolapse uterus, or is that something completely different?
That's different. That prolapse can happen as a woman gets older. And so those ligaments that were holding it up the uterus are now weakened. And what happens is that the uterus has no more support. So
is that reversible?
Well, they can put a pessary in. And they fit the woman. A pessary looks just like, very similar to that of a diaphragm, I can equate that for you like that. And so what we do is we fit the pessary to fit the woman. And then she can keep that in, and then she could take it out weekly. Some women come into the clinic actually to have the nurse practitioner take it out, clean it, and put it back in. But it holds up the uterus nice. Yeah. Otherwise, they have to have the uterus taken out, you know, but that's a prolapse. This is actually where the uterus that's should be staying inside there comes out.
So they'll take it out if it's like, they'll take your whole uterus out if it's too bad?
Well, there's two different ways. Now, if I just have inversion, we can put that uterus back up. Okay, the patient will go under either general anesthetic or conscious sedation so that the physician can push the uterus back into place. If she has a prolapsed uterus and she's uncomfortable and because it feels like a corn cob when you're walking. So, you know, it may be very uncomfortable for the elderly. The geriatric patients say maybe she's in her late 80s, 90s, and they may have to take it out. The uterus shrinks as you get older, you know, and you're not feeding it any more estrogen and progesterone as you go past menopause. So it actually shrinks down, and so sometimes you can get them out vaginally when patients elderly. That's a better way. Okay, so here's another slide on hypovolemic shock. I think you need to know this, don't you think? So your signs and symptoms, I know you know tachycardia, and that's what you'll see the most, you know, really quick. So your patient should be having a slow pulse after delivery, and all of a sudden she's showing 120 or 118. Wait a minute, what's going on? So take the blood pressure. I got hypotension now. That patient looks kind of pale. She's a little clammy. And if you don't recognize those signs, they'll go into a mental status change. And then, of course, the kidneys will get involved because the heart and everything is taking all the blood. And so there's decreased blood flow to the kidneys too. Okay, so here's a question. The nurse is monitoring a postpartum client who is bleeding for signs of shock. Ooh, so which indicates an early sign of shock? Oh, you know this one. Yeah, too. Yeah, sounds familiar. Okay. All right, here's mastitis. For our gentlemen in the group, this is painful. This is a swollen, as you can see, very edematous breast, very red area. This is what we want to avoid. We want, you know, mom's breastfeeding. A lot of times, I'll tell you what, babies like to latch on to the nipple, and mom doesn't know any better, so she lets them, and then it causes cracked nipples. Not good. So they kind of feel like they have the flu. They might even have pussy drainage. Not good. That means it's infected. So you're going to use antibiotics, make analgesics, frequent pumping, and that hurts. As you can tell, this probably hurts. This is why women
away, right?
Pardon?
You throw that milk away?
Yeah, if she's got pearly drainage, you don't want to give that to your baby. If she, this is where we lose our ladies because they'll say, forget it, I'm not going to breastfeed anymore. Yeah. Let's dry up. I've had enough. I'm going to do formula. It hurts too much. Some warm compresses, support bra, and of course, PO fluids. Now, these are all different other infections. This mastitis is one that can happen during postpartum. Endometriitis is another common infection where the inside of the lining of the uterus gets infected. Okay, and where it can start, guys, is right at the side of the placenta. You know, when the placenta comes off, there's a whole area that's open and exposed. So that's where you can get a good infection. You want to give her some antibiotics and some, you know, she may have some pelvic discomfort. And this is a big one. You'll see, this is where they usually put this in the scenario, foul smelling discharge. I think that kind of rings a bell. I think that was on exam number 3 also. Okay. And then cystitis, a urinary tract infection. We always teach correct care after urination. Keep everything clean. Make sure she has fluids. You know, and fluids are good. Fluids are good for increasing the production of milk. Fluids are good to keep the body clean and keep the urinary tract free of infection. You know, you don't want anything just sitting there for a while, so you want to keep it clean. And then, of course, you do your peri-care every time she urinates or has a bowel movement. And then wound infections, another opportunity for her to get infection is through a cesarean or your laceration or episiotomy. So that's why we went over RETA, and here it is. We already did that. So those are things you're going to look at during postpartum. So it's not good. And what's the best way to prevent any of this?
Hand washing.
Hand washing. And hand washing considered as what? Standard precaution.
Standard precaution.
Right, you got it. Okay. So here's another question for you. So Ms. Scott, how about you get this question? The nurse is monitoring a postpartum client who is at risk for developing postpartum endometritis. Which finding, if noted during the first 24 hours after delivery, supports the diagnosis of postpartum endometritis?
One.
Yeah, one. And the reason is because endometritis is what? Inflammation or infection in the lining of the uterus. Okay, good, very good. Okay, how about another question? The nurse is caring for a 1-day postpartum client. Which client assessment requires the need for follow-up? Okay, so now you got 4 first day, 1-day postpartum clients. So which one needs need for follow-up?
4.
Number 4.
Good, good. I tell you, they love putting foul smelling odor. Okay. And that's always a sign of
wonderful.
It's always the one that needs what? Follow-up. Okay. Because the client with colostrum, it's okay. That's normal. Colostrum is good, has all the antibodies. The client with a pulse rate of 60 beats per minute, that's okay because that's acceptable because it's on the low side. The client with mild after pains, that's normal. So it's 4. Good. Okay. All right, and then we talked already about the Holman sign, and we talked about the different thromboembolic disorders. So we got this down. If you need to go over a little more, go ahead. Here's a question for you. The nurse is developing a plan of care for a client recovering from cesarean delivery. Which actions should the nurse encourage the client to do to prevent thrombophlebitis? Tell me. I heard 3. Everybody agree?
Yep.
Yeah, get them up out of bed. Okay. And that's not only for a cesarean for a maternity, it's also for your med-surg patients. We get patients up now right at the surgery. Get that Foley out, get them up at the bed. And I've had women and men too. Oh, leave that, you can leave that. You don't have to get it out yet, nurse. No, you got to get up. They don't want to get out of bed, and it's better for them. So we have to tell them. Okay, we went over already postpartum blues, over postpartum depression and psychosis. So I just want you to know that postpartum blues, baby blues, it peaks around the 5th day and subsides about 10 days post-op, post-delivery. It does not impair any of her functioning, and she continues to bond with her baby, okay? It's just sometimes they don't get enough sleep, they're tired, they're not eating, or they cry. Babies can, sometimes some babies don't even go to sleep, and so mom doesn't get her rest. That's what can throw them right into these postpartum blues. And then if it's longer, when it lasts more than 2 weeks, then you get into depression. And a lot of times on a test, they'll have that scenario and they'll describe it. And it may say she's experiencing this for over maybe now it's 3 weeks. And so that should ring a bell to you that this is more, what, lasting longer, okay? And so it's more intense. And so therefore it falls under postpartum depression. All right? Okay. And again, she has feelings of detachment and lack of interest. So we kind of went over that already. All right. And then postpartum psychosis. This is where she has the bizarre behavior, guys. Now, a lot of times bipolar, when your patient has bipolar disorder, they can go right into psychosis after delivery. So you have to be careful with those patients, okay? These are reflexes. They're come right out of your textbook. A lot of times HESI likes the following reflexes. They love the gag reflex. Gag reflex is a survival reflex. The Morrow reflex, or the startle, wakes the baby up. Maybe there's something, maybe you hit the crib on the side of the bed and it startled the baby. Sucking. Sucking is another survival reflex because it's got to eat, right? So we want to make sure that these basic reflexes are present at birth for the infant to survive, to eat, okay? And that's how, if you're gonna, when you go back to study about that, that's what you want to do. Now, the last HESI had the Babinski on. So, because the Babinski, what happens, the newborn's toes will hyperextend and they'll fan apart from the dorsal flexion of the big toe. So, you know how you stroke upward on the baby's foot, you know, and their little feet go flat, they go out like a fan. You see my hand? And so that's a positive. That's okay. That's the only time that you're able to have a positive Babinski. So they had that on. And then bathing. They usually have this in scenario, but just know that you bathe from the head to the toe, and what actually it has the last to do, right? Wash head last. Why are we gonna wash the head last?
That's where they lose all their heat.
Right. Thank you. Oh, I love it. I love it. I love when you help me out. Okay. What's the first stool the baby puts out?
Meconium.
Meconium. So it should be the first 48 hours. Okay. They could have something like the time on that. Okay. If a baby's born, if the baby passes meconium in utero, he's at risk for meconium aspiration syndrome. So you have to be very careful when a baby's born that you go ahead and suction the baby out. And we suction at the perineum. As soon as the head comes out, we use wall shucks. I talk too much. Suctioning. And then when the baby's born, the next contraction, you actually see the baby come out. We take the baby over to the radium warmer. And then we have RT in there for respiratory therapy. They'll intubate the baby, do some more deep suctioning, bring it out, and do as much as we can to get that meconium out, because meconium aspiration syndrome could be deadly to the baby. Okay, so here's your question. The nurse is caring for a breastfed newborn. What will the nurse expect the stool color to be in 5 days after birth?
Yellow.
Yellow.
Right. Okay, so in your book, they have a really nice picture of the different stools. So if you want to take a look, they would probably ask about this. They would put in the days after birth. And then, of course, you know that black and tarry would be what? Meconium. And that's right after birth. And this is a different skin things you see. Mellow was on your exam number 3, and that's just little, not, I don't say pimples, but papulas. And they're just sweat glands on the nose. And infants don't sweat, remember? So for the first 24 hours. Okay. Mongolian spots. They like Mongolian spots. They're a bluish black pigmentation. These are Mongolian spots right here. And they're most common on the back and buttocks. Okay. Now there are people from like Latin America, Africa, Mediterranean. It actually looks like a bruise sometimes, but it does fade over time. Okay. And you have to be really careful with this kind of child coming through the ER, because you know, what am I suspecting?
Bruising, beating.
Child abuse. I'd be real careful. And then you have langugo, which is your fine hairs on the body. They often disappear during the first week of life. Okay. So if you're in, remember Vernix caseosa? Remember that one? Does this baby have Vernix on him? That's that white, cheesy looking substance that protects the baby's skin. So integumentary is all the skin problems that a baby's born with. Acrocyanosis, remember, is normal in the first 24 hours. That's it. So after 24 hours, they should be perfusing out to the hands and to the feet. So if you're not, then you need to pick up on that, okay? But it's normal in the first 24 hours, okay? All right. So a question for you. So right after birth, when the skin of the baby's trunk is pinkish, but the soles and the palm of the hands are blue, what is that called?
Acrocyanosis.
Oh, you made 100. Okay, I'll give you 100.
Oh, stop.
So here you go. This is on the head. Remember, the head can mold, fit mom's pelvis. Thank goodness it does. And baby can come out looking with a little cone head. That's called molding. Now, you got capus succedaneum, and you can see where that is. And then these are an area that's over the scalp, right? And right down, it crosses the suture line. Now, it does disappear in about 3 to 4 days. Okay. The subhematoma is a collection of blood, and that one is like it's sort of like on the side of the head, and that one does not cross the suture line. Does not. Okay, and then of course, you know, it gets reabsorbed because it's blood. The hemolysis will occur, and then what happens? That gets reabsorbed into the blood system. Now, fontanelles, you have 2, right? You got interior that looks like what, a diamond shape, and then you have posterior, which is more of like a crescent. What I want you to remember is when a fontanelle is depressed, that's a sign of dehydration. When a fontanelle is bulging, okay, that could be it's increased cranial pressure. All righty. So I got a question for you. On a newborn's head, the nurse notes, that's my little puppy. The nurse notes a swelling of the scalp that does not cross the suture line. Which one is that?
C.
Hematoma.
Yeah, it does not cross the suture line, right? It's on the side of the head. Capus succedaneum is back here, and it crosses the suture line. All right, we got time for a couple more, and then that's it. What is the nurse's best response to a mother who is voicing concern about the molding of her 2-day-old son? Oh, just say, hey, you know, the molding, it doesn't cause any problems. Don't worry about it. Would that be something?
D.
Yeah. Yeah, the baby's head forms the shape of the canal. It'll go away, absolutely. Would you ever say that? Oh, the molding doesn't cause any problems. Would you ever say that?
No.
I hope not. No. Oh, don't worry about it. Or how about that? A traumatic delivery can cause molding. Oh, should probably go crying about that one. And then, did you deliver vaginally or cesarean? Oh, don't matter. Okay. All right. We went over the signs of respiratory distress. If you're finding that you can't remember it, you want to probably spend a few minutes and go in your HESI book and look that up under new. Okay. All right. Mm-hmm. Here's a question. So what symptom associated in the newborn shortly after delivery should be reported?
Mm-hmm.
C. Right. Remember we talked about sternal or chest retractions.
Not good.
Yeah. It's the newborn just delivered, and that should be reported. Okay, good. All right, because mucus draining from the nose, that's kind of normal, right? All right, remember we got the bulb syringe, suction mouth, then nose. Okay, got cyanosis of the hands and feet. That's acrocyanosis. That's okay. all right? And then irregular heart rate, he may have irregular, but he'll convert very quickly. But this here is not never good. All right. About the first void, you always want to make sure that the baby voids. It must void in the first 24 hours. I seen that as a concern, as a question. Okay. They did have, let me remember, one of the HESIs, they did have about hydrospadias. So if you're not good on newborn with the urinary tract, look that up. But hydrospadias just means that the tip of the penis, the urethra is not in the middle, it's over to the side. On those kind of babies that have to have surgery, you do not do circumcisions. That's because you might need that beautiful foreskin to help correct that. It can be corrected. All right. You know, and with circumcisions, always worry about what? You got pain to worry about for the baby. You need a consent form. You have a bulb syringe at bedside. The baby's kept warm, okay? And you always watch for bleeding, okay? Now, if you do it before the baby goes home from the hospital, you have to worry about bleeding because vitamin K doesn't start producing until day 7. So it could have more bleeding because he doesn't have the clotting. That's why we give vitamin K injection. Okay. All right. Let's see. Pain is always a problem with newborns. Okay. Newborns do have pain. Know the different scales between the different FLACC, and then you have the different ones here, NIPS. And these are all premature and MPAS, and you have price. Okay. All right, guys. I think I'm going to stop here. If you're not up on pretermers and the complications, you want to go over it. Again, but remember, pretermers is they lack surfactant. And so they're not able to keep their lungs inflated. So that's why we give mom beclomethasone 2 injections IM prior to delivering her. And then after baby's born, we'll send baby to the NICU, and the NICU, they can intubate the baby, and they'll give the steroid, they give surfactant and elixir, okay? Usually it starts to work within 72 hours. Remember, we want to be very careful when we give oxygen to a preemie, okay? Because we can cause that baby to go into what? Bronchial
pulmonal dysplasia.
Yes, good. And so remember, the oxygenation for a preemie is 92% or greater. All right. So you guys were great. I'm going to stop here because we talked about all this already. Well, that we did. Let's see here. Additional complications. Yeah, go on. I'll be given this slide, everything with this video, so you'll have it, okay? So we got pretty good through everything. I hope you enjoyed your review. Let me stop sharing. And I'm stopping here because I respect your time. It's time now. It's almost 5:30. It's like 5:29. And I want you to have a good night. You did great today. And get your HESI book out, okay?
It was a pleasure.
Anything, guys, you can email me.
Thank you.
You're welcome. Okay.
Thank you for having us in your class.
Oh, you're welcome, Jacob. It was really nice meeting you. You're doing very well. You're all doing great. Patrick, it was good seeing you again.
All right, we'll see you next time.
Yes.
Sure. So we'll
Bye-bye.
see you week 12 then.
Yeah, we will meet week 12. Yep.
So
remember,
next week, HESI, and
yeah,
that's it.
It won't be very long because I want to talk to each one individual. So I'll be sending out a schedule and tell you what time to come into the Zoom, and then the other person will exit, and then you'll come in. It's going to be very symptomatically, system, and we'll get through it. But the main thing is that I see you week 12.
Okay.
Okay.
All right. Thank you so much. Bye.
You're welcome. My pleasure. Good luck, everybody. Happy studying. Okay. Let's see here.